I'm going to begin here, and we'll try to get our recording problems underway as soon as we can. So, welcome everyone to the Clinical Performance Improvement Network, using results from patient experience surveys to improve care in the practice setting, and very specifically using the results from the recent patient experience survey done by the Puget Sound Health Alliance. And we will be hearing today from Susie Dade from the Alliance and Larry Morrissey, a physician who has used these types of data to make improvements in his practice. Let me do a little bit of housekeeping, and we will then begin. CPIN is a collaborative production of the Foundation, the Puget Sound Health Alliance, and the Washington Academy of Family Physicians. If you are having technical difficulties, please contact Michelle at the number on your screen. A word about CME. If you would like CME for this presentation, if you're a physician, we are happy to do that. We've changed our process a little bit this year, so as noted at the bottom of the screen, to request CME credit for this session, please send an email to me at lance@wsma.org, and I will make sure you get your CME credit. And as discussed a few moments ago, if you're having technical difficulties getting the visual portion, you can follow along with the PDF file, and you will still certainly qualify for the CME credits. Now let me introduce our two speakers. Susie Dade is the Deputy Director of the Puget Sound Health Alliance and is the person most responsible for getting the patient experience survey launched and analyzed, and she will be giving an overview of the findings from that patient experience survey. Since that is a very recent patient experience survey, and we don't have anybody in this market area yet who has actually begun actively taking the results, we went elsewhere, and we have Larry Morrissey from the Stillwater Medical Group in Minnesota, who has used similar patient experience survey results to make improvements in his medical practice. So without further ado, let me open the presentation and turn this over to Susie.
Great. Thank you, Lance. Can you hear me?
Yes. If you could speak a little louder, that would be great.
Okay. Great. So thank you very much for having me join you today. I appreciate the opportunity to be here to share the results from our recent release of a report that we're calling Your Voice Matters, and it includes results on patient experience with primary care providers in the Puget Sound region. To start, I'd like to offer just a bit of context and to talk about why we believe this is so important. In 2001, I think all of you on the call know that the Institute of Medicine released its report, Crossing the Quality Chasm. And as you know, the report laid out 6 aims for healthcare: safe, effective, timely, efficient, equitable, and of course, patient-centered. The IOM report offered a compelling challenge to all of us to achieve major gains in all 6 of these dimensions of care delivery. And at the time, the framework was almost entirely centered around quality as the system property. But it's been my observation that over the last decade, this has really expanded to include the concept of value, with quality as one of the foundational elements. Increasingly, there is a lot of emphasis on understanding and addressing waste in the system, and we are increasingly focusing on overuse and misuse with an eye always on cost. But I believe that we've yet to really embrace or achieve system-wide prioritization of what we would call patient-centered care. And by way of an example, I've really been somewhat surprised as we've rolled out these results by how many providers just don't really know what we mean by patient experience or how it ties to quality and outcomes. Puget Sound Health Alliance and its 165 member organizations are on the road together to high-value health care, and it's that spot in the distance here in the slide that's all aglow. Most days it feels like we're making headway, but the road still stretches out ahead of us with a pretty good distance to go. Most of us agree more or less on the variables of high-value health care. Is care provided in the most effective and safe manner? Is it even needed? And if so, is it provided efficiently? Are patients realizing the best possible results, and are we doing so at a fair and ultimately affordable price? And is the care provided in a way that is patient-centered? The Alliance has staked out its strategies. These are activities that we believe the community is better off doing together so that we can align our efforts to avoid all the confusing and ambiguous signals that exist today, including different expectations, different incentives, different measures. You'll see here on one of the road signs, measurement is at the top of the list. This is one of our distinctive competencies. We believe community-wide measurement, it's really hard work, but it's essential to achieving our goals. Without it, we don't have a common answer about where we are, and we don't know if we're improving what we don't measure. And in the case of patient experience, we don't know unless we ask our patients. And this slide is not an eye test. It really is a little bit fuzzy, but in case you can't read it, it says, when we want your opinion, we'll give it to you. And so, we turned to looking at patient experience, and the first thing we really wanted to do was to think about why patient experience is so important when we are focused on improving quality. First and foremost, experience is how patients think about quality. For them, it's about the personal interaction and the results that they experience. Building trust between patient-provider and, in fact, the entire healthcare team is really foundational to patient engagement. People need to not only be welcomed, but to feel valued in the relationship. And experience is not just about patients feeling good. There's a growing body of research that shows that patient experience is a major driver of both patient behavior and their health outcomes. So, for example, poor relationship predicts a lack of follow-up with preventive recommendations and chronic disease management. Poor communication and continuity predict hospitalization. And poor experience of access or wasted time in the office predict no-shows and overuse of outside urgent care or emergency rooms. But on the flip side, good relationships predict better self-care, increased patient adherence to prescribed meds, and follow-through on screenings. Good communication predicts reduced duplication of services, less demand for diagnostics that don't add value, and fewer medical errors. And good experience with access predicts proactive use of primary care for ongoing care. At the heart of it, these are the reasons that patient-centered care is included in the 6 aims, and we can't really get to quality without also focusing on the patient's experience. But if all of this isn't enough for you, patient experience is also good for business. Positive experience builds patient loyalty to a practice and to a provider, so that not only do they keep bringing the business back, but they recommend their providers to others. And patient experience is also linked to malpractice. The better the experience, the lower the risk of malpractice. So I get asked this question a lot. Isn't this just semantics? Isn't patient experience the same thing as patient satisfaction? And actually the answer is no. There is an important distinction between the two. Patient experience includes satisfaction, but really focuses on whether or not or how often certain events or behaviors occur. That focuses on areas that are shown to be important to patients and that are linked to improve health outcomes. And importantly, the results actually highlight actionable areas for providers to focus on for practice improvement. In contrast, patient satisfaction really sort of get more at the patient's expectations or feelings and are considered much more an indicative of business loyalty and are not particularly correlated with improved outcomes. So when we decided to do this survey, we looked around for what tool we should use, and we chose the CG-CAP survey, which has rapidly become the gold standard in measuring patient experience in providers' offices. The tool was developed by AHRQ and endorsed by the National Quality Forum. It's been rigorously tested to ensure validity and reliability, so results are much more dependable than what you'll find on most rating websites and sort of the Angie's List type thing. Focus group testing has been important in making sure that the results that are reported publicly are understandable for consumers and meaningful for providers. So we mailed the survey to 90,000 people in a two-wave mailing. We did a small third wave to try and pick up a couple of additional clinics that had a low response rate. That's why it says 2+. We got return surveys back from 32,000 people. Overall, we had about a 36% response rate, and for any of you who do these kinds of surveys, you'll know that this is actually a very good response rate. Overall, our respondents were predominantly folks that had been going to their provider for at least 3 years, in their middle years, female, in pretty good health, college-educated, and Caucasian. This is overall for the region, and it varies somewhat by medical group or by clinic.
Did you mention that this is from insurance?
So on May 11th, we released the results publicly, and you can find them on our website, which is wacommunitycheckup.org. We have included results for 4 measures. The top 3 are composite measures, and the 4th is the response to a single question. We are reporting top box scores, which means those scores that reflect the best performance on any given question. So, for example, if it asks how often something happens, we are reporting the percentage of patients that say it always happens. We have results for 40 medical groups with 156 clinics. In the written report that we produced, we show results comparing to both the regional average and the regional 90th percentile, but on our website we only compare to the regional average. Only measures that have a sufficient number of responses to be considered reliable are being publicly reported, but medical groups and clinics actually got all of their results, regardless of whether we're publicly reporting them. And then all the scores are case mix adjusted for patients' self-reported age, gender, education, and health status. So here are the results for the region, and I'll just explain real quickly what this is. The red box on the bottom is the results for the lowest scoring clinic in the region. The green box is the highest scoring clinic. The purple bar is the regional average, and the gold diamond is the regional 90th percentile. And across the bottom are the 4 measures that we are reporting publicly, always getting timely appointments, care, and information, whether or not office staff are helpful, provider communication, and then the overall provider rating. And I will say that these 4 measures are measures that are recommended for public reporting by the National CAPS Consortium, and so that's why we selected these. But the medical groups and the clinics themselves in a private report got their results to every question in the survey. So not just the composite results, but all the detail. So there are really multiple opportunities for improvement here. First is the variation that we see within the region. We want to shrink that variation with lower performing practices, identifying and addressing their specific areas for improvement, hopefully having the opportunity to learn from higher performing clinics, which is one of the benefits of transparency. And then not shown here is also the variation within larger medical groups. So multi-care or Swedish or group health, for example, that have multiple sites, you would see variation among those clinics within the same medical group as well. But a second area of improvement is really that we want to move the entire region to a higher performing level so that our average becomes among the best in the country. This chart really shows an array of the results of the 40 medical groups' performance, and it shows the range of performance and opportunities for improvement. The vertical axis is the number of publicly reported measures, which is 4, and then the groups are shown how many of those measures they're either above average, average, or below average with the green, gray, and red. In the future, this will be a different picture when we begin to compare our performance to best practice nationally. This is shown as being above, at, or below the regional average, and I think we'd all agree that the average is not what we're aspiring to. I think in future reports that we do, we'll be looking to compare ourselves to the national 90th percentile as we strive for excellence. So our survey vendor did a pretty cool analysis for us called the key drivers of the overall rating of provider, where they actually took the 22 performance-related questions and correlated them with the rating of provider at the clinic level to identify which patient experience measures best explain variation in the overall provider rating. And I won't read these to you. There are 8 of them, and combined, these 8 variables explain 84% of the variation in how patients rate their providers across clinic sites and medical groups. Not surprisingly, these results reaffirm what the evidence already points to, and that is that provider communication is paramount in affirming the patient's experience of care. This is not to say that timely access to care and information isn't important. It is, and it's very important as we work as a region to reduce avoidable ED visits and hospital admissions. But without that really meaningful and positive interaction with the provider, patients don't learn to trust and rely upon their primary care provider and his or her team. So this is a shout out for the high-performing medical groups where I've shown who are the top 5 or 6 performers at or above the 90th percentile on each of the select measures, and you can read through those, and there's a lot of repeats. You'll see that some perform well across the board. And then finally, another shout out to the high-performing clinics. Out of 156 clinics, only 7 had above average results on all 4 measures, and you can see them listed here. For the most part, what these groups have in common is an established culture within the practice that sort of starts at the top with the clinical leadership, placing a high value on patient experience that's then built into their hiring and their training and their processes and evaluation so that it really becomes the way that things are done, where the patient is known and there's a focus on communication, patient understanding, teaching, access to information about their care and timeliness of appointments, responsiveness of staff, and coordination of care. These are the things that drive the really excellent results across the board for these groups. I'm going to just finish up my last slide here. These are results or specific questions that we're not reporting on a medical group or clinic level, but I thought they were interesting and they represent opportunities for improvement for us as a region. There's a lot of good news about the survey, but there's also news about things that we really could be doing better. And here's some of the results about our region-wide performance in areas of known risk factors like healthy eating, physical exercise, and smoking. But probably most striking here are the results about screening for depression, where 59% of patients said their provider did not ever ask them whether there was a period of time when they felt sad or depressed. And this is important, of course, because we know the effects that depression can have on patients' engagement and their adherence to provider recommendations about other important things like their use of medication, diet, exercise, regular testing for monitoring conditions. So while we've got a lot of great successes that we need to celebrate, there's still a lot of room for improvement in really bringing about a culture in our region on patient experience. And I think Dr. Morrissey is going to come up next to help us understand how his group has really used the results from the CG-CAP survey to improve practice. And I've put this last slide has my contact information on it. Lance, did we mail out the PDF of the report?
Yes, we did.
Okay, so all of you should have the full written report, and then on our website here, wacommunitycheckup.org, there's a lot more detail with specific statistics and so forth at the medical group and clinic results. So I think that's it for me, Lance.
Thank you,
we'll
Susie.
do questions at the end. Is that right?
Yeah, I think that's probably the best way to do it.
Great.
So we
Thank you.
leave time for Larry. Thank you. While Larry's slides are loading, I would like to again encourage people to hit *6 to mute your line if you're not a presenter. We're getting some unfortunate background noises out there, and if we can have those eliminated, it makes for a much nicer presentation. So I hear a lot of clicking going on, which I'm hoping means people are hitting *6. So Larry Morrissey, the physician from the Stillwater Medical Group in Minnesota, will now talk about how his group used these findings to make practice improvements in their medical group. So Larry, go for it.
Thank you, Lance. Can everybody hear me okay? Lance, can you hear me?
The volume's fine, yes.
Okay, great. And of course, immediately after you give me the chance to talk, my partner's phone in the office starts to ring, and I can't go hit mute
so that's
on it.
yours.
So
Okay.
I apologize. I apologize for that.
Stop soon.
Yes. Well, thank you, everyone, for giving me the chance to talk today. My name is Larry Morrissey. I'm a pediatrician from Stillwater, Minnesota, which is a small town just outside of the Twin Cities. And I work at a large multi-specialty clinic, which has a long history of working in this area, and we actually were, I'm going to talk about it a little bit, but we actually kind of helped when they were originally testing the CG CAPS questions in the clinic setting. We were one of the first groups to try them out. I worked as the medical director of quality improvement for Stillwater Medical Group for 8 years during this period of time, and this project is one of the things that I really put a lot of emphasis on in that role. So I've kind of been there and been through the rigors of all of this, and I hope to share with you some kind of real-life experiences of what goes on with patient satisfaction surveying. These are just the objectives for what we're going to try to do today. It's hockey season, so I put the Stanley Cup on there. But Susie kind of hit on why we do this. And really, when you're talking about either the 6 aims or the triple aims, patient experience is an extremely important component of it. And I kind of view it as sort of a foundational thing that allows you to achieve the other things you're trying to do. A lot of the other things that you do within the 6 aims are really technical in nature, and the experience of care and patient-centeredness is really more basic than that, and it's something that's an adaptive change that you have to make in yourself as a person to try to achieve the goal of being serving other people. And it's a challenge because you all come into this feeling you do that well. Everybody wants to do well for their patients, and everybody feels like this is why I do this. This is part of my job. And as Susie said, the business case is that it's going to bring people back. This is a picture down in the bottom of my family at Glacier National Park, and when you have good experiences, then people want to return, and you know, we think of that vacation that we want to go back on because we know it was a great time, and we want our patients' experience in the clinic to be that way. And as a quality improvement person, you know you need to measure in order to do well. And it's not fun to measure, and it's not easy to measure, but you have to have data in order to understand where you are. And as a leader, you in your own organization are responsible for sending a message. And if you want people who you work with to view patient experience as being important, you're going to have to send that clear message that this is something that we need to do. And hopefully as you make that clear amidst the chaos of all the things that they're trying to accomplish, having this be a high priority can also be kind of connecting with the people at your work because they want to do a good job at this. This is what they came to work for. And that's part of why when I first started as Quality Improvement Director, I really focused on this. It's a picture of my daughter Elizabeth when she was first learning how to stand, and I love this photo because there's sort of a joy in her face of her doing her job. And it shows the immense patience of our golden retriever in the process, but it really, for a lot of people, giving patients a good experience is what brings joy to their work. And that's something that you can really call to them to make it important. And it's what called to me as an individual to want to do this better for our clinic and to really get our level of awareness to a different plane, because we were working under the assumption that we were doing this well, and we needed to know more. So Susie touched a little bit about the difference between satisfaction and experience, and we've all had the experience. I bought a car recently, and you get a call from the automaker, and the person who sold you the car says, you know, you better give me a 10 or they're going to take away my dog. But reality is that everybody's reaction is, from a satisfaction standpoint, going to be a little bit rosy because they like you as a provider and as a person. And where experience surveying becomes really important is that it gives you something concrete. It looks at the basic building blocks that you need to have to give that patient a good experience as they move through your system each day. And the questions that are asked in these surveys are specific, actionable things that you can look at closely to make sure that you're doing this well in order to bring the patient a good experience. And we'll talk a little bit about some specific examples where people try to work on that, but it's those specific, actionable elements that really are the difference between just thinking that somebody likes you and actually looking at, are you doing the right things to make sure that they have a good experience. Now, the clinic versus individual data is a little bit of a challenge in this situation. You guys are going to be receiving sort of clinic level data and looking at variation there. And when I explain to you some of the things that you do, we did at Stillwater, you'll have to keep in mind that we went the extra step to collect enough data to get down to individual provider feedback around how things are going. And that is challenging because it's more expensive and more work, but when we started, we were working at a clinic level, and we realized that we wanted to go further as an organization, get it to that individual level in order to really work on the variation that exists. It's a little easier to digest and communicate the information at the clinic level because it's not quite as threatening. When you look at how you're doing as a group, it's just, here's all of us together. It's good in the sense that it promotes a sense of teamwork and focus, but it's a little challenging because at the individual level, the data becomes more personal. And I share with everybody very openly that here I am, the person who's going off and giving webinars to people in Seattle, and when I got my individual data back, I was near the bottom in my own department, and that kind of shook me. It was hard to see that because I thought I was doing a good job, but I realized that I wasn't, and I realized that there were things that I could do better. And when you can get people to come to that place, then you're going to be able to start to move the bar. And I think you do have to be careful of the I'm not the problem. And this picture is a picture of my 3 kids. The girl who was pulling up to stand in the earlier picture is over in the corner with the twins hat, and her younger brother Colin is, as usual, blaming her for something that happened. And a lot of times in patient experience surveying, it's the other doctor across the hall who's the problem. It's not me. And what you need to do as a team is get everybody to start to get to that self-awareness of we all can have things that we can work on to do better, and we all can kind of rise up to that. And I think what Susie talked about, that change in your culture so that everybody is comfortable with talking about how we make things better and how we work as a group to try to move things forward is really important. So the results let you see where they are, and I think I really like her comment. You want to focus on reducing variation. This isn't about being perfect, and this isn't about everybody's going to have a perfect experience every single time. And it does help to sort of, focus in on some specific areas and makes it easier to act. If you try to boil the ocean, then you're going to be disappointed because you're never going to succeed. Now, these are a few slides that just have some specific questions that she kind of referenced previously. But I think the reason for putting them forward is that you can see in these questions that they are pretty concrete, and asking people these questions allows them to look at specific things that have happened and give you feedback. And I think as you look at the research surrounding this, the more specific you are, then the better data you get. The provider action ones, I picked out before Susie had her slides, and I think we ended up picking ones that were all on that list. And it's because we, as an organization, when we looked at our own data, we did that same kind of analysis that she did and got correlation between these specific questions and which ones are the key drivers to make patients feel like their overall experience was good. And that's part of what drove what we picked to focus on when we were working on individual areas. And there are staff questions as well, but they all kind of come back to these business outcome of, would you recommend this group to somebody else? And that really is a part of making this case compelling to people within your organization, because this is what you want. This is your best advertising. This is your best way of making sure that your patients are going to be positive about you when you talk about someone else, is to make sure their experience is good. So I kind of mentioned earlier, this is just a slide with some details about our group, and we're a kind of a larger multi-specialty group. Some of the data that you'll see will be specific to departments, and others will be across the whole clinic. But I will try to show you some examples of some specific data, and I'm also going to talk about 2 other health systems within the Twin Cities who have done things to show you that it's not just Stillwater Medical Group who's working on this. This gives you a little sense of our history. We, as I mentioned earlier, back in 2004, we helped with the very beginning pilots of the CG CAPS survey. CG CAPS is a little different than the health plan CAPS in that it is administered at a clinic level. The health plan is sort of at a plan level, and the data behaves a little differently in those 2 settings. And in Minnesota Community Measurement, much like Puget Sound, has piloted statewide public reporting on this, and we participated in the 2 statewide pilots, which are the green boxes there. One was in late 2008, and the other one was in the middle of 2010. During this period of time, one of the things that we'd made this decision about as an organization after the first community measurement survey, but before the second one, is that we went to this idea of continuous surveying with individualized provider feedback. So we survey at a rate that we get 60 completed surveys per provider per year, and that information can be fed back to those individuals at an individual level, as well as allowing us very robust data to look at a clinic level. And that was a major organizational investment for us, and it shows kind of the senior leadership commitment to doing this, that we were willing to put our own money on the table to make this happen. So one example of a question that we acted on as an organization was the one of, did the provider give you easy to understand instructions about taking care of your health? And that was one of the key drivers that Susie mentioned earlier. And we happened to start working on this around the time that we were getting ready to implement. We have a version of Epic in our clinic, and we were getting ready to implement it. And we realized that this was sort of like the Reese's Peanut Butter Cups, because it was both a patient experience positive thing, but it was also a requirement for meaningful use to work on implementing the after visit summary. And we recognized that we could kind of be doing two things at once here. And it was great because it had a lot of inherent ability to collect data around improvement. And these next few slides I'm going to show you, we kind of used the meaningful use data and the patient experience data and brought them together to see things. And the other thing, which I think is really important, I kind of brought this up a few times, but the leader of the EMR implementation, when he started to work in this particular area, he was somebody who needed to improve on this question. And he saw a huge impact in his scores when he started to use the after-visit summary as a part of his practice to the question, did you provide easy-to-understand instructions? And that was really an aha moment for him that, hey, this is a point that we need to emphasize. And I think it really helped us move things forward. So I'll show you a little data here. This is just a small trial. This was over about a month period of time in two different departments. And you can see that the internal medicine department had a little bit of an issue with the score on that question, and they improved significantly after they implemented the AVS. And that was kind of a wow, it generated a lot of energy. However, the family practice department wasn't really using the AVS, and we were able to go back to that other department and say, hey, look, these guys got better. Maybe you should think about that. Now, it was a 1-month period of time, and obviously internal medicine didn't stay at 97.4, but it did seem like it did have a positive impact. I don't have a statistician, so I don't get to give you p-values or anything like that. I'm quality improvement, not research. So there were some barriers to using the AVS tool as a way to help improve patient experience because it was hard to get people to do it consistently at first. And it was partly because it took a lot of time, and we needed to make sure that there was useful information that people could put on there to make it worthwhile. And as we went along and we're trying to implement this and work on this question, you'll see in the data that there was some instability in the data, and I think some of these challenges make it hard because things kind of go up and down. Because there's a lot of things that can affect the answers to these questions. But we address them by seeking out early adopters, trying to show people that it was successful, and we were able to improve the rate at which people were doing it quite a bit in a relatively short period of time. And as we did, we were able to look at what was the relationship between how likely someone was to use the AVFs and what was the score on the question. And you can see that there was a pretty positive correlation there. Again, it's not perfect statistics, but this was enough to motivate people to say, yeah, we need to work on this because it does seem to help. Now, this is a picture of Ziggy Wolf after the Viking Stadium got approved by the legislature. But we were all pretty happy, yet things don't always go as well as you planned, like my pager going off in the middle of the presentation. But you can see that the score over time has been a little bit unstable. There are times when we get it going better, and then there are things that seem to affect it and go down. And that's going to be true of patient experience surveying. One of the things that's different about your survey than ours is that ours is visit-specific and yours looks over the last year. That's going to make your scores, because it's looking over a year's period of time, a little bit more stable over time than ours, and you're not going to see this kind of variability. But keep that in mind, that there's a lot of factors that can influence how people respond to this kind of question. And you have to realize it's more of a journey than it is you're going to get to an end point. And a lot of things that you do implementing a quality improvement, you get it fixed up, it goes pretty well, and then you're just good. And maintaining the gains is always hard, but I think particularly in patient experience surveying, it's something that you're going to have to be mindful of, that there's so many different things that can affect the outcome that you're probably going to have a little bit more challenge keeping things at a good place. So there's another major health system, Allina Health System in the Twin Cities, and they focused a lot on improving access. And I know that that's an area that Susie had mentioned earlier. She is looking at as a place where you guys have some room for improvement. And so I'm bringing their story to you as another example of another group completely different from us who worked in this area. They looked at their access issues and identified some key things that they thought were lacking and tried to change. One of them was their phone process and how they handled people when they came into the system on the telephone, and improving the accessibility and getting somebody the right answer on the first phone call really helped free up people to focus on their own work, because they weren't, it wasn't taking 6 phone calls to get a problem solved. And so by making specific changes in their phone process to try to make the patient flow through more easily, and an example that they gave was that when the person has somebody on the line, instead of just transferring somebody, go with them to the next phone call and say, I'm talking to Joan and she has this question. And that way they were able to make sure that things went smoothly, and it sped everybody up. And this kind of scripting of how do you talk to people was an important element of that. Also, they were able to more effectively use their EHR to kind of make sure that the right information was going forward with the patient to reduce some of this duplication. They implemented open access in certain places where it wasn't there. And another really interesting thing that they did, and this relates to kind of the patient wait times questions, is that sometimes you get this message from the phone people of, could you come a few minutes early to fill out the forms? And it really created a sense in the patients of, I'm always waiting too long because I got here early and then I had to sit around for a long time. And what they did was they actually kind of changed their process so that there was almost sort of a 2-phase element to the appointment. There was a period of time when the person was supposed to arrive, and then they made it clear to the patient that you're supposed to be here at 2. We intend for you to see Dr. Jones at 2:10, but it's going to take us 10 minutes to bring you through the process of rooming. And we have a lot of things we need to get accomplished then before your appointment with Dr. Jones at 2:10. And all of a sudden, the person doesn't feel like they're waiting in the room quite as long, and that sense that their patients had about these questions with regard to wait time to seeing the provider improved a lot because they kind of redefined the expectation. And I thought that was a neat example of a pretty specific, concrete operational process that you can do that really helps make your patients feel like there's a better experience. The next thing that I'm going to mention is what's called shadow coaching, and this was developed by Health Partners, which we are a part of at Stillwater Medical Group. And they've had this program for a while. And the basic idea behind shadow coaching is that you train a group of non-clinicians through a pretty rigorous training process to learn how to observe specific behaviors in physicians and mid-level providers as they interact with patients. And you're assigned a shadow coach who is basically with you for one day. And I've actually done this myself. The person I was with, he was the director of home care and hospice. And he came and followed me around for one day. My patients were told this guy is going to be working with Dr. Morrissey. He's just going to be standing off in the background. And the patients have the opportunity to opt out if they don't want him in the room. But he followed me around and just watched what I did. And it was interesting because I was sort of on my best behavior because I knew I was being watched, but it made me more conscious of some of the things that I know I don't really do every day all the time, and helped me see, boy, I need to focus in. And the example that I gave, and Susie cited this question earlier, there's a pretty good correlation that if you know the patient's history before you go in the room, they're going to be happier about their experience. And I'm somebody who sometimes would just go in there and get started without looking at the chart first. And when I'm better at looking at the chart before I go in the room, then it's a better interaction with the patient because I look like I actually know what's going on. And at the end of the day, the shadow coach gives you a concrete feedback about what you're doing and then gives you some pointers of you could do this a little differently or that a little differently. One example that he gave me at the end of the day is I tend to ask somebody, do you have any other questions? And in doing that, I sort of shut down any previous discussion we have because by saying other questions, it means those previous questions are over, buddy. We're not going back. Anything else or I'm leaving. And he said, if you could change that to say, did I answer all of the questions you have today well? Then you're going to open it up for the person to be able to say, I really didn't understand what you were talking about earlier. And it's a little bit of, as a provider, you get a little nervous because now all of a sudden I'm reopening the can of worms that I thought I had closed. But in reality, you want to know that because you don't want the person walking out of the office confused, and you want them to have the chance to say, I just don't understand this. And so it was a good, again, concrete, simple example of something that I could do differently in order to make things better. Shadow coaching, I think, is a challenge, and I put a picture of Punxsutawney Phil up here because a lot of people are afraid of the shadow and will run into their hole for 6 weeks to see if the shadow will go away. But for the people who experience it, it is a great thing, and if you can get over that initial fear of this isn't going to work for me, it actually gives you a lot of good feedback. There have been some organizations who've tried it and haven't had good outcomes, I think partly because they didn't sort of set things up right for people to know this is what you should expect. But Health Partners has had tremendous success with this, and the person who runs the program shared with me that 71% of the people who go through the program have an improvement in their scores after completing the program. And so I think that was pretty impressive. And my last slide is just some things for you guys to keep in mind as you're doing this. And I don't want to be too gloomy, but it is important to remember that it's hard to maintain very high performance. And if you have a good organizational culture, that creates a stable environment. But keep in mind that there's a lot of things that affect patient experience, and you're going to have ups and downs. That results do vary, and it can take some time before you see change because of how your question is worded and the fact that you're looking at a year-long period of time. But hopefully, if you kind of get in there and stay with it, you'll be able to improve the experience that your patients have and really connect with your employees and providers in making them feel like this is a good thing for me to do. And that's the end of me yapping.
Well,
so, Lance, back to you.
Yeah. Thank you very much, Larry. That was very helpful and very educational to see how you took results and then actually did things. So I would now like to encourage everybody to make noise by, again, hitting *6 to unmute your lines, and we can have a discussion with both Dr. Morrissey and Susie Dade about both the survey that was done here and about how to use these results. So let me open it up and see what questions we have. Anybody?
Hi, Lance. This is Amy Howing. I was just wondering if anybody was aware of, of any, I'm intrigued by the shadow coaching, and I wondered if Susie knew of any programs around here to train people with that or how to get that set up.
Well,
this is. I'll let Susie go first, and I can answer. I'll give an answer too.
Okay.
Okay, Susie first, then Larry.
Okay.
I don't know. I don't have a roster. I do know that during my time, I worked for quite a long time at Group Health Cooperative, and during that time, and I've been gone from there now for quite a while, but when I was there, we did quite a lot of work with physicians and other types of providers around their interactions with patients, and we did use some shadow coaching. So they might be a resource, and I can check with them and see. And I would be interested too, after Larry answers, whether there's anybody else on the call, because we have a large number of people on the call. Sure. Whether any of those delivery systems are working with specific coaches that they could recommend.
Great.
So I did ask Cheryl Magnuson-Giese, who runs the Health Partners program, how I should answer that question because I figured it might come up. And she said if somehow through Lance you can get your email to me, Cheryl would be happy to talk to some people who are interested to at least give you an overview of how she was able to put this program in place at Health Partners, because she did it by learning from somebody else, and so she might be a good resource for you too.
Oh, great. That would be wonderful. Thank you.
That's a great offer.
Yeah,
I won't turn it down.
Offer, and I encourage everybody to take her up on that offer. Amy, I have your email, but others who are interested in this shadow coaching concept and want to learn more, send me an email. And if I get a lot of interest, I may see if we can get that person, I forgot her name already. I'm sorry.
Cheryl.
To do a little sort of mini CPIN webinar for those people who are interested in shadow coaching, so she doesn't get the same question, 10 times in a row. But that's a great offer. Yeah.
Yeah. That one slide I did with the groundhog is actually boiled down of a 30-minute presentation that Cheryl gave. So there's plenty there. She does a great little presentation and talks about the history of it and how they went about doing it in a lot more detail than I was able to provide. So.
Yeah, particularly if they have a sort of a coach's guide to things you should look for to really pay attention to. That would be helpful. Okay, so that's a great question. Other questions? Anybody else out there? Well, while you're thinking of your next question, let me go to the overall introductory slides, which was fast. Okay. We have a evaluation for this session, and the link is on the screen if you want to copy that down. It's also in the materials we sent out to you ahead of the thing, and we will also send it again when we send out the certificates of continuing medical education. So please do take the evaluation. The survey results are really important to us in improving our CPIN programs as we go forward, and I read each and every one of them, I promise you. So please give us your feedback. This also gives me a chance to again mention that if you want CME credit for this, you need to send me an email. And my email is now on the screen. Particularly those of you who did not log in, or if you're in a group and I only have one person's name, I'm not going to know you participated unless you send me the email asking for CME certification. So please do that. And a good example of that is I would not have known that Amy was on the line because she signed in. Somebody else signed in. So if you would like CME credit for this, please do send me an email. We've got a few minutes for additional questions. Anybody have additional questions for either Larry or Susie? Well, I know there's still, a lot of people on the line. If for some reason you have a question and *6 did not unmute your line, you can type it in the chat area on your screen, and we can get questions that way as well. Any questions?
Larry, go ahead.
Go right ahead. No, go right ahead.
Larry, this is Amy again. I find it difficult to encourage people to see the need for change, and I kind of appreciated your maybe gentle way of doing that. Do you have any other tricks, any other way to encourage that stubborn person who thinks it's all the people next door, I guess?
Well, a couple of things. One, you'll notice there was a pretty big time lag between 2004 and 2008. And we spent a lot of that time working on organizational culture at Stillwater Medical Group and getting people to a place that they were more comfortable with getting data about how they were doing. And, I think a lot of the work that we did around diabetes care and trying to make that better, if you look at a chart of our diabetes scores, we were near the bottom when we started, and we were well above average now. And I think we built a culture to say that we do want to look to try to make things better, and that takes time. And it took us 4 or 5 years to get people to that spot. And so I think being persistent about it and saying this data is not going to go away, we're going to keep looking at this is a key element of that. And I think the other thing is you have to be sensitive to this. There are people who are really ticked off at me for doing this. I'll be totally frank. There were people who wouldn't even look me in the eye when I walked down the hall after we put the first results out. And there were other people who were in my office crying. And I think we were pretty sensitive about the fact that this is a sensitive area, and we were careful about not being too transparent too quickly because it took people time to get comfortable with this. And I think that's another thing you have to be watchful of. But trying to get people to connect to that message that this is what you're trying to do, this is important to you, and we know that. Don't be afraid of the measurement is a hard thing, but it's an important message. And I kind of joke too. One of my best friends, who's down the hall in the office down the hall from me, he can't believe I'm talking to you guys on a webinar. He's like, "Quit telling people to do this." Like, no, it's a good idea, really, and they know it. And he's coming around, but some people just struggle with it, and you just have to know that, just like people struggled with their diabetes numbers. And there are a lot of people who said, hey, we shouldn't be bothering with this, we can't make this better, but lo and behold, you can. And there's an article in New England Journal that heart attacks are going down in people with diabetes now. And so it does make a difference, but you have to be persistent.
Yeah, this is Susie. I would just add that one of the things that I hear most often from physicians and other providers that begin to engage in measurement of important areas of care is that in the beginning they all felt that they were, clearly wanted to do a good job and just sort of knew in their heart of hearts that they were, A+ students and were doing great. And many of them surprised at the results. And so I think it's sort of dangerous territory to always assume that you know how you're doing, particularly in the area of patient experience, but in other areas as well. And so that's why measurement and reporting results is so important, is that not only do you get to see how you're doing, but you understand how you're doing in comparison to your peers.
Great.
So thank you both. We've got like 1 minute left, so a quick question for Susie. Is there any plan to repeat the survey in the future that you guys have just done?
The Alliance will make a decision about that this summer. I'm hoping yes. I think it's highly likely.
Okay. Well, thank you very much.
There is a question on the chat thing about getting a copy of the questions, and I think Susie sent it to me, so she must be able to send it to everybody. But you can also go on the internet to CAP's website at ARC, and they have a lot of good information there as well.
Yeah, I'm happy to send it, but the entire survey and a lot of information about it is in the public domain. And if you just Google the letters CGCAHPS, you'll have everything that you'll ever want to know about the questions and the survey protocols and everything.
Okay, well, I will send that link out when we send out the evaluation link as well, so that everybody gets access to that. I do want to be conscious of people's time. It's now 1:15. Thank you both very much for a really outstanding presentation.